Okay, so we're going to talk about hybrid imaging. Again, if somebody could unmute and just check you can see my screen.
Yes, we can. Thank you very much.
Excellent. Okay, so a bit like the infection, I'm going to cover some SPECT-CT and PET-CT so that we can cover both, because the techniques are very similar, just obviously tracers. Some tracers are better being SPECT tracers and some being PET tracers. So we're going to start off with parathyroids. Now, I'm sure you do lots of parathyroid imaging and probably don't need me to do too much on this, but if you remember, there's various different groups of patients who may suffer from hyperparathyroidism. It is said to be more common than hyperthyroidism, but I think that's only by people who want to take out people's parathyroids. So in terms of diagnosis, it can occur in patients, for example, renal failure, where you can get primary and secondary, or just occur spontaneously as a primary disease. And the diagnosis is only really ever made by blood tests. So they have a blood test with a high calcium or a calcium at the upper limit of normal. And then they will have a parathormone test. And if that's elevated, that's the diagnosis. But our job is really localization, because as you know, there are 4 parathyroids in most people. And it'd be very helpful for the surgeon if they know left or right, upper or lower, because this reduces operating time and also reduces morbidity, and you can use very small surgical scars. And the reason it's important is that there's a different approach from the upper and lower, because you've got to avoid the recurrent laryngeal nerve, which sort of runs diagonally. So they tend to do the uppers from the front and the lowers from the side. So getting that right is important. And that helps to keep the morbidity of the operation down quite significantly. And they can use minimally invasive techniques, which means that they're not quite a day care, it's often a 1 or 2 day operation. The other time we get asked to do it is when they've done the operation and the patient's calcium and parathormone hasn't decreased. That's either because they've missed the adenoma or it's an ectopic adenoma. Now, by doing good imaging beforehand, we should try and reduce the need for these second looks. So the 2 main methods which are used to localize the parathyroid are ultrasound, which obviously it says readily available, but if you try and get a thyroid ultrasound, there's often quite a long list. But it needs a skilled operator to know what they're looking at. And obviously we'll only image the neck. So if you have an ectopic in the chest, it's not going to help you very much. It doesn't have a radiation dose, of course, and you may find other thyroid pathology, which you may or may not want to find. Nuclear medicine, possibly not so readily available. You do need to have a skilled reader, but we do scan really from the chin down to the chest, so we can pick up ectopics. And we're not so bothered by other thyroid pathologies. And depending on how you do it and what trace you use, the radiation dose is between 4 and 24 millisieverts. But most people now are doing just MIBI, which is about 4 millisieverts. So what we do in nuclear medicine, is we exploit the functional differences between the tumor and background tissue. Now, what would be really, really good is to have an agent which is only taken up by parathyroids and not taken up by anything else. And certainly in the SPECT world, that doesn't yet exist. They're sort of getting there in the PET world. So some of the agents have uptake in both thyroid and parathyroid. Just going to mute you all. Whilst other ones have just thyroid. So as we don't have an agent which just has in the parathyroid, if you take an agent that has uptake in thyroid or parathyroid and you subtract the thyroid, you should be left with parathyroid. So that's the basis of the subtraction technique. Now, the other technique is to have what's called a washout technique. And this is all related to the number of mitochondria in each cell, because things like MIB and tetraphosphamine are stored in mitochondria. So the parathyroid cells are full of mitochondria, so they retain these traces for much longer, whilst a normal thyroid has less of these, and therefore it washes out quicker. Now, with tetraphosphamine, the washout for thyroid is still quite slow, so we tend not to use that, so we stick with the MIB. So this is a subtraction technique, and what you do is you inject a tracer which is taken up by the thyroid or parathyroid. If you like irradiating your patients and spending lots of money, you can use thallium, but these days we would tend to use MIB. You wait 30 minutes and then we scan the neck, and then keeping the patient under the camera, we then inject a tracer taken up by the thyroid, such as iodine 123 or Metomidate. We wait 15 minutes and then we scan, and what we end up with is a series of images. So this is a particular set of images that one of my colleagues who works in Kent took. So there's an iodine 123 image, which is the thyroid, and then there's the MIB image, which has got the thyroid and the parathyroid. Now that parathyroid is about the size of, I wouldn't say a grapefruit, but probably a small orange. So probably anybody could find it really. And then when you subtract them, the thyroid signal is subtracted and you find your parathyroid. Now this works very well for very large tumours, but it works less well for small tumours and those tumours that have low-grade uptake. So the washout technique was developed in France in the 1990s, and that's because they found out that it washed out the different rate between the thyroid and parathyroid with retention in the parathyroid. So you inject the MIB, wait 5 minutes, take some pictures, and then you wait another hour and a half to 2 hours and you take some more images. And originally that was done with planar images, but now we do with SPECT and SPECT-CT. So this is a patient, this is a late image, this is at about 90 minutes post MIB injection. And you can tell it's MIB because there's a very nice bit of myocardium there. And here we have uptake on a SPECT scan, and you can see there is uptake here in the anterior chest. So this is clearly an ectopic parathyroid adenoma. So the easy thing is you have an ectopic parathyroid adenoma. Well, that's the easy bit. Now you've got to do the difficult bit and say exactly where it is. And without CT, that's very difficult. So here we have the same patient with a SPECT-CT, and you can see that this is a prevascular anterior mediastinal node, which has uptake, sort of node, parathyroid adenoma. So it can lie anywhere between the arch of the aorta and the chin. So here we have a nice little ectopic parathyroid. Now, if you looked at the CT alone, you'd make the mistake I just made a minute ago and call it a prevascular node, but it isn't. It's actually a parathyroid adenoma. So that's how we can use it, and it's particularly good for ectopic parathyroids. More commonly, though, we see the uptake in the thyroid area, and then you need just a little bit of skill because the theory is a thyroid washes out a bit faster, but in reality, it's often not that much faster. Now, fortunately, nature has helped us because what element is the thyroid stuffed full of? And that is iodine. What does CT use as a contrast agent? Iodine. So in a non-contrast CT, effectively the thyroid has got contrast in it. So it appears denser, whiter on the CT. So that tells you where the thyroid is. And what you can see here is there's a sort of bit of thyroid on that side, a bit of thyroid on that side. It's a little bit more behind. And when you look at the SPECT-CT, you can actually see much more clearly. There's a second structure behind the thyroid, and that's the parathyroid adenoma. And that's about 11 millimeters from what I can see. Now, I would say that 90% of the parathyroid adenomas you will be finding will be this kind of one behind the behind the thyroid. Now, also, that's the top of the thyroid, that's the bottom of the thyroid. So it's not quite at the very bottom, but it is a lower parathyroid. So it will be a right-sided lower parathyroid. And that's all you need to tell the surgeon. They'll find it after that because they'll know where to operate and find that tumour. Now, when we did lots of audits and publications, we found that ultrasound found about 90% of parathyroid adenomas, and MIBI found about 90%. Not always the same 90%, but there were about 7% of patients that were negative on both ultrasound and MIBI. So the question is, could we find a PET agent that worked with this? And this was some work that was done in Germany. And they imaged 33 patients, not with MIBI and SPECT-CT, but with C11 methionine and PET-CT. Some of these patients had previous surgery, some of them had other issues as well. But what they were able to do was to find very small tumours, about 4 millimeters, whilst with SPECT, in reality, the smallest you normally find is about 7 millimeters. Other agents have been used, C11 choline, but more importantly, because it's fluorine labeled, is F18 choline and F18 DOPA. There's also a product called F18 fluciclovine, which is licensed in some countries for prostate imaging, and we'll talk about that in prostate PET, but that also probably works as well. So this is from Cambridge. This is a C11 methionine study. And you can see here, you don't get the thyroid uptake. So here is your parathyroid adenoma shining out like a little beacon very nicely behind the thyroid. You do get uptake in bone marrow, so you know where you are. But this very clearly localizes the parathyroid adenoma. It's just a very expensive way to do it. So this is some results of some work that we did, looking at we looked at 180 patients with primary hyperparathyroid. They had MIBI and ultrasound. And if you remember, I said that 90% will be found by those techniques. So 170 or 163 were found, and about 10% of them, i.e. 17 patients, we couldn't find a parathyroid adenoma. So they went on to have a C11 methionine PET. It was still negative in 5 of these, probably just too small for PET to find out, but positive in 12. And this is the negative ones. Eventually they had the surgical assessment, except for 2 patients, and they had a mixture of things, but small adenoma was in 1 patient. Hyperplasia is also can give you a secondary hyperparathyroidism, but doesn't really get cured by surgery. And to be honest, in 3, we never really found anything. In the positives, we had 8 with surgical follow-up, and 7 adenomas were removed, with 6 going back to normal calcium. So just to show you some examples, this is a 78-year-old person with a calcium just above the upper limit of normal. 2.8 is the upper limit for us, so it's 2.9 is above it, but quite a high PTH at 286. It shouldn't really be more than about 80. Had a neck ultrasound, and this is the MIBI. We've only got the planar image, but the SPECT-CT was also negative. And the C11 methionine was done. And if you notice very carefully, the reason they couldn't find the parathyroid adenoma on ultrasound is because it's not in the neck, it's behind the trachea. So it's a retrotracheal parathyroid adenoma, and therefore it's an ectopic one. Now the patient, 63, a bit of a higher calcium there, 3, but interestingly, the parathyroid level is lower. She underwent selective venous sampling, and they thought there's a mediastinal source of parathyroid tissue. The MIBI really was unhelpful, but on the C11 methionine PET and PET-CT, this is the coronal image, there was an absolute tiny, sort of 3 millimeter lesion just behind the sternum, and we put a red arrow on it to help you find it because it's so small. So other people have used MIBI going back to the larger ones in terms of intraoperative work. So some, like we did with sentinel node, they use the same probe to try and find adenomas. there was a few people in Turkey that are very good at doing this, but we never really caught on. I think partly because with the imaging, the surgeons are so fast. I've seen a surgeon take a parathyroid adenoma out in 4 minutes after we localized it on MIBI. You can't really get much faster than that. So what about, you then have a cyclotron and your MIBI's not working. Fortunately, there's a nice trial from Austria that compared MIBI and F18 choline in 76 patients. And though the here you can see that the orange bar is specificity, it's very similar. The sensitivity of the MIBI was only around about 70% in this group because they're small tumours. But in the F18 choline, it was about 93%. So without a loss of specificity, you have a much better sensitivity. And from this paper, they've now agreed to reimburse F18 choline parathyroid imaging in the UK. So moving to a different gland now, we're talking about the adrenal gland. This lies in the retroperitoneal space. The right tends to sit above the right kidney and tends to be squashed against the liver. And the left sort of sits just a little bit above, but primarily more medial to the upper pole of the left kidney. Now, there are two parts to the adrenal functionally. There's the cortex, which makes cholesterol-based steroids, and particularly aldosterone and some of the androgens. And there's the medulla, which makes the catecholamines, such as adrenaline. So depending if you want to look at the cortex and medulla, then you need to use different types of tracers. So this is just a very nice example from one of our CT scans. So in a way, the left adrenal looks more like a sort of Mercedes triangle, and the right one is, because it's squeezed against the liver, looks like a Mercedes that's been on that road between Joburg Airport and Pretoria and met one of your taxi drivers is a bit squashed. Shouldn't be rude about taxi drivers, should I? So what about cortex? So you can do cortisol levels. CT and MR may be helpful, but it would be quite nice to know if it's producing too much, for example, aldosterone, which is what's called Conn syndrome, which is the only really curable form of hypertension. And when I was at medical school, we were told it was 5% of hypertensives. In fact, it's about 15%. It's much more, just that people weren't finding the adenomas. But if you could remove the adenoma, you cure the hypertension. And as it tends to occur in younger patients, that's really quite important. So for a long time, we only had iodine 131 I19 iodocholesterol, or the wonderfully named selenium 75 beta selenomethyl norcholesterol to image with, and both of them produced really awful pictures. I mean, the selenium took 2 weeks to be localized, and at the 14-day image, you put them on the gamma camera at about 9 o'clock, have breakfast, have coffee, maybe a bit of lunch, then get them off the gamma camera about 12, and you might have a picture if you're lucky. So again, people have looked at drugs, and Metomidate is a drug which is used to block the release of aldosterone. So it was fairly easy to label with C11. So C11 Metomidate is the start of all this process. It's still got a fairly high radiation dose, it's not too bad. So the first paper came out in 2012, 39 patients with Conn syndrome. Now, what they also did is that they give some ordinary steroids just to suppress normal aldosterone and steroid production. So only the adenomas would have uptake. So a bit like you do with a thyroid. With a thyroid adenoma, it suppresses the normal thyroid. So we don't have the equivalent of that. So we give the steroids for a few days, 3 days, and that does the equivalent of damping down the normal adrenal uptake. So you see the abnormal And this was the SUV showing that with dexamethasone, the normal cells, the activity goes down compared to baseline, and in the abnormal cells, it actually goes up. So this is from Burson's paper. So normal uptake, if you look at Metomidate PET, and because it's C11, you normally just do the liver area. It's about 15-minute one bed position scan, and you can see uptake in both adrenal glands. In this one, it looks a little different. This is actually the coronal image, and you can see out here on the lateral part of the left adrenal is a focus of abnormal uptake. And this corresponds to this small adenoma here, which is about 6 millimeters. So these things can be very, very small. But it does mean they can be removed without taking out the whole adrenal. This one may be a little easier to see. This is a transverse one, and you can see here a 6 millimeter adenoma, again, just on the medial aspect of the left adrenal, and it's got intense focal uptake of the tracer. But you were saying that we don't have a cyclotron, we can't make C11. Well, there's a new carbonyl ethyl metomidate that's become available called Capito, and this can be labeled with fluorine. So we're just starting some trials, first of all in Cambridge, and then soon we will be doing them at Barts, looking for Conn's tumours with this agent, which can be made and sent around. You don't need your own cyclotron. And here we have quite a big adenoma. This is one of the patients from Cambridge, and you see the intense uptake of the F18 Capito. The other thing is, because of the longer half-life of F18, you don't need to scan until half an hour, and then you get much more intense uptake. So it's actually easier to read the scan. So the future of this looking for Conn syndrome is probably this fluorinated product. So what about the medulla? Well, that's involved in the catecholamine system, and as we know, we can image that with SPECT tracers with MIBG, probably also with F18 DOPA and dopamine in PET, but it hasn't been used so much with these particular PHEOs. And from PHEOs, they tend to, as I say, class themselves as benign and malignant. I'll show you that in a minute. But MIBG is basically like the precursor to adrenaline and noradrenaline, so it's taken up by the active mechanism, actually coded through something called the VMAT and VMAT1 and VMAT2 gene. But there's lots of drugs that stop it, particularly the only illegal one is cocaine, but the legal drugs, they tend to be the old-fashioned drugs like for blood pressure, like methyl dopa reserpine, which nobody should be on anymore. And some of the tricyclic antidepressants are a problem as well. Because it's iodine, we need to do thyroid blockage so we don't irradiate the thyroid. So you can give up to 400 megabecquerels. It's quite expensive stuff. That will be probably $1,000 US, even in the UK. But even if you could buy it in South Africa, it would be more expensive. You image at 24 hours, and then you normally do planar and SPECT-CT. And in PHEOs, there's generally the rule of tens. So the pheochromocytoma results in intermittent production of adrenaline and noradrenaline, so you can get paroxysmal headaches, increase of blood pressure and palpitations. Tends to be more common in younger people because they probably already had a stroke otherwise, and they'll die quite young. So they don't really get very old unless you take it out. So 10% are said to be malignant, 10% are bilateral, 10% are ectopic, 10% are found in children, 10% are associated with the MEN2 syndrome, and 10% are negative on an MIBG scan. So this is a whole body image of a patient who has a pheochromocytoma, which is about the size of a tennis ball. Now, it's really important that you know about these, because if they think this is just an adrenal tumor and they don't protect the patient with alpha and beta blockers during surgery, you can quite easily kill them. Now, I showed you one of an MIBG in the SPECT-CT tumour section. And the thing is, these tumours tend to be either malignant or endocrine. So where you put them, it doesn't really matter. But this is an MIBG study showing this is uptake around in a liver metastasis. They've actually tried to embolize it, but not very well, as you can see. There's the embolization coil, and here is the living metastatic pheochromocytoma that the coils have all missed. Now the images are reasonable, but maybe better to use Gam68 dotatate. The indium doesn't seem to work very well, but the Gam68 dotatate seems to be quite good. And then you have the option of doing PRRT as well. You can use, again, C11 methionine. So C11 methionine is just an amino acid. It's a very basic substance, but it is taken up in growing cells. So just inflammation is unlikely to have much uptake. Now, the other important thing is that unlike FDG, there is no normal brain activity of C11 methionine. So you get a very high uptake compared to background, which you don't get with the FDG. And so you can use it to image brain tumours, any kind of brain tumour, to be honest. And it was really developed to look for post-surgery recurrence of tumours. But it can also be used in pituitary tumours, and pituitary is, once you've got the pituitary, you've got the endocrine system again. So pituitary tumours produce either TSH or ACTH or growth hormone. They can be non-productive, in which case what they do is they destroy the cells that make these hormones, and then you get something called Sheehan syndrome, where the pituitary becomes non-functional. Now, this is the famous Pharaoh's operation, is they go up through the nose, underneath the brain, and they try and remove it through the sphenoid plate. It's called the Pharaoh's operation because when they mummified pharaohs, they would use the same place to pull the brains out. Just a lovely thought, isn't it, really? However, if symptoms persist or there is residual biochemical change, and these patients tend to have residual disease, you've got to try and find it. So you can use an MR, and here's an MR looking at, this is with gadolinium. What you can see is that's where the surgeon has nibbled out a bit of the pituitary. So they've come up through the nose and nibbled that bit out. That's why it's a black hole. But somewhere in there could lurk some more pituitary adenoma cells. So this is the same patient. This is the CT from the PET-CT, and you can see that's the sphenoid cells here. And what we see is, in fact, if you look carefully along the edge and on the top, i.e. along here and along here, that's where the residual adenoma is. So we can tell the clinicians that they basically need to go back. Now, you may say, what's this hot uptake? That's in the nasal mucosa. So you don't get confused between that and the pituitary. These are different patients. So on this patient, you can see very small adenoma in the pituitary bed. It's around about 4 millimeters. On this patient who's had a bit of surgery, you can see that the sphenoid plate has been broken. Again, there is some, they've cored out the center, but they've left the edge of the tumor. So there is some residual pituitary adenoma around the edge. Sometimes it's easy to see things in the sagittal plane because here you can see the pituitary fossa. And again, notice the bone is missing from the bottom. So this patient's been operated on, and you can see that this is the sella, which is tunica, which is meant to be like a Turkish saddle from a Turkish soldier, but probably not many Turkish soldiers around anymore, but it's the same kind of saddle as people who go, cowboys who go out and, so cowboys should be cow people now, shouldn't they? Because they're gender neutral. who use their horses to, particularly in the US, to herd up cattle. And it's the same kind of high saddle. So the idea is that you can sit in it and your hands are free to lasso your cow. And in the back of this, if you think of the saddle, in the back of the saddle here is some focal uptake of the C11-methionine. So there's a tumour in the posterior part of the pituitary. So all this is very useful information. Some work was published in Brussels about 15 years ago, comparing methionine PET, MET as they called it, MET PET, with MR, and found that almost every single tumour was found with methionine PET, but only about 60% found with MR, and that's our experience too. So we're coming to the end of our first day. So I'm just going to finish off with one of these rather rare syndromes. This is the hyperinsulinemia of children. So this is a rather strange disease that occurs this is not an insulinoma that occurs in an adult. This is where there's a general overproduction of insulin from the beta cells within the pancreas. Now they can be diffuse or focal. If they're diffuse, there's not a lot you can do about it other than a total pancreatectomy, because these children can't be hyperinsulinemic for too long because they end up getting hypoglycemic comas and get brain damage. So they'll end up on insulin, obviously, to take their pancreas out. But if they're focal, then you can use microsurgery to try and remove that part of the pancreas so they have some retained pancreas. And there's been a project that's been running for around about 7 years now between Great Ormond Street in London, where some of you may know Iski Gordon, where he used to work, and University College London Hospital. And they've been working on doing F18 DOPA imaging in these patients based on an American paper which shows that you can find focal lesions. This is the only centre in the UK that does it. So this is from the Capito paper, and there's 2 patients. The first one is shows a fairly diffuse uptake, and then the second one shows very much more intense uptake, and this is meant to help guide surgery. When this study will be finished, we don't know. They're trying to recruit about 25 patients, but the number of cases in a year is about 5. So if you go back to the very origins of nuclear medicine, we started with endocrinology. Saul Hertz, who was the first person to use this technique on humans, was an endocrinologist. So we start in endocrinology. So it's good that we continue to have that interest. The functional nature of endocrinology is very well suited to nuclear medicine, better than anatomical imaging. But you need to find really specialized tracers often, because you need something that really links in with that endocrine process. And in some cases, we can use this to direct radionuclide therapy. Now, the one thing I haven't discussed are carcinoids and neuroendocrine tumors, because I'm going to talk about that in the PET-NET lecture, which I think is on Wednesday. Okay. Excellent.